Hello friends, welcome to Creative Medicine. In this lecture, we will learn about
Amino glycosides. Amino glycosides can be of two types. One we have mycin, MYCIN, and second we have mycin, MYCIN. So these mycin are actually derived from streptomyces. So example of this streptomyces is streptomycin. Whereas this MYCIN, this is a semi-synthetic form. So in the semi-synthetic form, you will see presence of netilmycin. So, how is amino glycoside mechanism of action? First, it diffuses from the outer coat. If this is the amino glycoside molecule, this will diffuse through the outer coat of gram-negative bacteria. In the gram-negative bacteria, there will be porins. So, it will diffuse from the porins and enters the periplasmic space. And in the periplasmic space, this is the cell wall, and this is the cell membrane. Now these amino glycosides from the periplasmic space through the energy dependent ETC oxygen dependent transport, they will enter into the cytoplasm. In the cytoplasm, they will bind to the 30S ribosomes and also 50S ribosomes, and thus they will inhibit the protein synthesis. They will bind to 30S and 50S ribosome and thus inhibit the protein synthesis. And they will also disintegrate monosome formation and aggregation, and they will inhibit protein synthesis and also disintegrate monosome and polysome formation. And thus at the end, the defective proteins are incorporated into the cell wall. It inhibits protein synthesis and it leads to the formation of defective proteins. These defective proteins which are formed, these will enter the cell membrane and they will form small pores on the cell membrane. So once they form small pores on the cell membrane, the content of the cell membrane is released outside, and as a result this leads to cell death. So amino glycosides will combine with beta lactams and it results in the synergistic combination. So if you see the pharmacokinetics, they have no GI absorption and they do not have GI or oral absorption. So they cannot be given orally. But we can give them either IM or IV, or you can also give them by topical route. So these amino glycosides have concentration dependent killing mechanism, and they also have post antibiotic effect. They have concentration dependent killing and they have post antibiotic effect is seen. And they are in low concentration in some substances, in some fluids in our body, like in synovial fluid, in pleural fluid, in peritoneal fluid, they are in low concentration. And they are in high concentration in endolymph. And in renal cortex, they are in high concentration. And thus they cause autotoxicity and also they cause nephrotoxicity. So they are in less concentration in the cerebrospinal fluid, and they are also in less concentration in the aqueous fluid of the eye. They accumulates in the they accumulates in the kidney whenever there is decreased GFR. That is, in renal insufficiency and in renal failures, the amino glycosides will accumulate in the kidney. So if you see the classification of amino glycosides, it is of two types. First, we have systemic amino glycosides are present, and we also have topical amino glycosides. So in systemic amino glycosides, these include, we have streptomycin, gentamicin, then we have kanamycin, then we have tobramycin, then we have amikacin, sisomycin, netilmycin, paramomycin, and neomycin. So So these are the systemic amino glycosides. Whereas in topical amino glycosides, we have pramicitin. So pramicitin or soframycin are topical amino glycosides. So in the systemic amino glycosides, this streptomycin is the one. This streptomycin is used as a drug of choice in plague. It is used as drug of choice in plague, brucellosis. It is used, and it is with brucellosis. In brucellosis, it is used along with tetracycline. Then this streptomycin is side effect of streptomycin is it can be vestibular toxic also. Then among all these amino glycosides, the most commonly used amino glycoside is gentamicin. This gentamicin is used along with penicillin, or it can be used along with ampicillin, or it can be used along with ceftriaxone. Here gentamicin is used along with penicillin, ampicillin, ceftriaxone for septicemia, and it is also used for fever in immunocompromised and subacute bacterial endocarditis. Then if you see the side effects, first we have nephrotoxicity. Nephrotoxicity, it is a reversible side effect. This nephrotoxicity occurs mainly due to the hypokalemia. It occurs due to pre-existing renal disease, and this nephrotoxicity occurs due to some nephrotoxic medications which were used by the patients. So maximum nephrotoxicity mainly occurs due to the neomycin. N for N. Maximum nephrotoxicity occurs due to neomycin, and this neomycin is not indicated for systemic use. Then we have the next, the least nephrotoxic, streptomycin. Streptomycin will result in least nephrotoxic. Maximum nephrotoxic is neomycin, and least nephrotoxic is streptomycin. And then nephrotoxicity caused by neomycin. Actually, neomycin is not indicated for systemic use. This is mainly a topical amino glycoside. Then if you were asked what is the what is the amino acid causing nephrotoxicity which is used systemically, that is the most nephrotoxic amino acid which is used systemically is, we have tobramycin followed by gentamicin. We have tobramycin followed by gentamicin. So tobramycin can be used systemically followed by gentamicin. Whereas this is the most nephrotoxic antibiotic or amino glycosides which is used systemically is tobramycin, whereas most nephrotoxic amino glycoside which is used topically is neomycin. Then if you see autotoxicity, in the autotoxicity is most commonly with prolonged usage, especially with high serum concentration of the amino glycosides being seen in the inner ear fluids. So it is most commonly causes autotoxicity, and also due to hypovolemia, or if we use these amino glycosides with other autotoxic medications, like itacrinic acid is an autotoxic medication. So if amino glycosides are used with itacrinic acid, then they result in autotoxicity. Now this autotoxicity is of two types. First we have cochlear autotoxicity, second we have vestibular autotoxicity. So in cochlear autotoxicity include amikacin, neomycin, amikacin, neomycin, and then kanamycin. So in cochlear autotoxicity, maximum cochlear autotoxicity is neomycin. Then vestibular autotoxicity is caused by streptomycin. Vestibular autotoxicity is caused by streptomycin and gentamicin. Cochlear ototoxicity and vestibular ototoxicity, both these are caused equally by tobramycin. So if you were asked what is the amino glycoside which causes maximum cochlear ototoxicity, that is neomycin. If you were asked what is the amino acid to cause maximum vestibular ototoxicity, is streptomycin. Then if you were asked what is the amino glycoside to cause both cochlear and vestibular ototoxicity, is tobramycin. Then overall maximum hearing loss. Overall maximum hearing loss is caused by amikacin. Amikacin will cause overall maximum hearing loss. Overall maximum hearing loss is amikacin. Then which is least ototoxic? Least ototoxic is by netilmycin. Netilmycin is the one which is least ototoxic. Then the next is neuromuscular blockade. Neuromuscular blockade, these amino glycosides will inhibit presynaptic release of acetylcholine, and as a result they decrease the sensitivity of postsynaptic receptor. They decrease the presynaptic release of acetylcholine, and thus they decrease the sensitivity of postsynaptic receptor. It is also associated with hypocalcemia. It is associated with peritoneal administration, and it is also associated with use of neuromuscular blockades. So when there is neuromuscular blockade, it will cause respiratory depression in the patients. Then the treatment of this neuromuscular blockade is you will have to give IV administration of calcium is given for the patients with neuromuscular blockade, because in neuromuscular blockade the amino glycosides are presynaptically decreasing the acetylcholine release. But if you administer calcium, this calcium will cause increased release of acetylcholine, and as a result the action can be decreased. Then which of the following amino glycosides causes maximum neuromuscular blockade? Maximum neuromuscular blockade is by neomycin and also streptomycin. Maximum neuromuscular blockade is by neomycin and streptomycin, whereas least neuromuscular blockade is by tobramycin. Maximum neuromuscular blockade is by neomycin and streptomycin. Then what are the uses of amino glycoside? In the amino glycosides, in the ATT, for anti-tubercular drugs, injectables which are used in ATT are actually amino glycoside antibiotics can be used as injectables in ATT. So the injectables which are used in ATT belonging to amino glycosides are, we have kanamycin, amikacin and neomycin are present. And for topical use we have pharmacetine and also neomycin is present for topical use. So these are about amino glycosides. Then we have new drugs. The new drugs or new amino glycosides which are available we have plazomycin. This plazomycin is used in complicated UTI. Plazomycin in complicated UTI. Then we have spectinomycin. Spectinomycin is used as an alternative to penicillin. In the treatment of gonorrhea, we use spectinomycin. Then we have paramomycin. Paramomycin is mainly used in the treatment of intestinal amoebiasis. Paramomycin is used in the treatment of intestinal amoebiasis, and it is also used in the cryptosporidiosis in immunocompromised patients. Then the next group of antibiotics is macrolides. Macrolides are large cyclic lactone ring structures with sugars. These macrolides will bind to 50S ribosome and they will block the peptide chain from moving from A site to P site. The peptide chain will move from A site to P site. So this translocation is blocked by the macrolides combining with 50S ribosome. Okay. Then the drugs which are important in macrolides are, we have erythromycin, then we have clarithromycin, then we have roxithromycin, then we have azithromycin, spiramycin and fidaxomicin. So these are macrolides. So among all these, what is the longest acting macrolide? Azithromycin is actually the longest acting macrolide, and this azithromycin has no enzyme induction seen, and this azithromycin has free drug interactions. So these macrolides can be used as alternatives to penicillin and penicillin resistant patients. So what is the drug of choice for macrolides? Macrolides are actually the drug of choice for organisms like chancroid, that is caused by Haemophilus ducreyi, and also Legionella. You can use macrolides can be used for Legionella. They can be used for atypical pneumonia. Then they can be used in whooping cough. And they are also used off-label for diabetes, gastroparesis. And then in the Mycobacterium tuberculosis, we have a macrolide which is called as clarithromycin, which is used in the prophylaxis and treatment of Mycobacterium tuberculosis. And in spiramycin is a macrolide which is used as drug of choice for toxoplasmosis in pregnancy. Toxoplasmosis in pregnancy, spiramycin is used. Then we have azithromycin. This azithromycin is used in Haemophilus influenza. It is used in atypical mycobacterial infections. It is used in Toxoplasma gondii, and in chlamydia species we can use azithromycin. So if you see the side effects, macrolides can cause diarrhea as the side effect, and the drug which is erythromycin will inhibit the motilin receptors, and as a result erythromycin will activate the motilin receptors. Whenever the erythromycin activates the motilin receptors, it increases the peristalsis, and thus it causes nausea and vomiting in the patient along with diarrhea. This erythromycin also causes cholestasis. Because it causes cholestasis, it is contraindicated in pregnancy. Then the other side effects are the macrolides can cause allergic reactions. They can cause reversible ototoxicity. They can cause Torsades D pointers. When they cause Torsades D pointers, they will prolong the QT interval. And the drug IV erythromycin. This IV erythromycin can cause dose-dependent reversible ototoxicity, and this IV erythromycin will inhibit a CYP enzyme, and thus this IV erythromycin, by inhibiting CYP enzyme, it increases the doses of the drugs which are metabolized by CYP enzymes. So it has dose-dependent ototoxicity is seen. And erythromycin, rosithromycin and clarithromycin. Not just erythromycin, even the rosithromycin and clarithromycin, these are also will inhibit CYP enzymes. Then if you give erythromycin to terfenadine, estomizole and cisapride. So if you give erythromycin to a patient with, so if erythromycin is given to any of the drugs like terfenadine or estomizole or cisapride, see, these drugs like terfenadine, estomizole and cisapride, they will prolong the QT interval. So if you give erythromycin along with all these drugs, so this will again prolong the QT interval furthermore, and this can result in polymorphic ventricular tachycardia. So this can result in polymorphic ventricular tachycardia. So if you see the pharmacokinetics, they are absorbed orally, and erythromycin is excreted by the biliary route, whereas clarithromycin is excreted by both biliary route and renal route also, whereas azithromycin can be given as single day dosing. So this is about the this is about the macrolides. Then after macrolides, the next group of drugs are, we have streptogramins. These streptogramins are synergistic combination of, we have streptogramin A and then we have streptogramin B. So what is streptogramin A? Streptogramin A is dalfopristin, whereas streptogramin B is quinopristin. Dalfepristine is streptogramin A and phenopristine is streptogramin B. These are in the ratio of 70:30. 70% of dalfopristine and 20% of phenopristine is there. So this 70% of dalfopristine with the 30% of phenopristine together, we call it as pristamicin. What is pristamicin?
Thank you, and thank you for watching.